Hi, everybody. My name's Amanda Duggan. I am presenting our case study along with Shira Rosoph. We are both fourth-year medical students from St. George's University. The title of our case is Conservative Management of a Patient with Pneumoperitoneum Following Cardiopulmonary Resuscitation. So as a brief intro, I'm sure you all know that pneumoperitoneum is the presence of air or gas in the peritoneal cavity where air is not supposed to be. And it can be the result of various factors such as tissue ischemia, erosion, infection, mechanical injury, or thermal injury, with the most common cause being perforation of an abdominal viscus. In rare cases, it can arise from various mechanisms during CPR or cardiopulmonary resuscitation. Our patient was a 64-year-old male with a past medical history of COPD and depression who presented to the emergency department with acute respiratory distress, altered mental status, atypical arrhythmia, as well as nausea and vomiting. He was tracheally intubated, and during intubation, he experienced cardiopulmonary arrest with pulseless electrical activity. CPR was performed for 30 seconds, and return of spontaneous circulation was achieved. The following day, some imaging studies were obtained. On chest X-ray, there was no evidence of rib fracture and no evidence of pneumothorax. However, his abdominal CT showed pneumoperitoneum, but it did not show signs of any perforated viscus. General surgery was consulted due to the pneumoperitoneum. So the following day, general surgery did examine the patient as requested and asked for a follow-up CT of the abdomen, which showed reducing in size of the pneumoperitoneum. So they proceeded to perform serial physical examinations. Of note on physical exam, the patient was critically ill. He was intubated and sedated. And most of note, he did have bowel sounds. His abdomen was not rigid, and he did not have any guarding or rebound tenderness upon palpation of his abdomen. The active problem list for this patient included acute respiratory failure, acute refractory septic shock with multi-organ failure, acute renal failure with metabolic acidosis, hypoglycemia, as well as coffee ground emesis. And if you want to have a look at our lab findings and vital signs, you'll see that all of that is reflected in there.
Okay, and so now if we take a look at the imaging, we can note that in image A, there is a pneumoperitoneum, and then image B essentially is the follow-up CT image that Amanda mentioned before, and it was taken one day after, and the pneumoperitoneum is already reducing in size. So now if we consider the management options, general surgery did look at both surgical and conservative management options, but in the end, they chose conservative for several reasons. One, like Amanda said, the physical exam findings show no evidence of peritonitis. Two, the chest X-ray did show no evidence of pneumothorax, and CT scan showed no perforated viscus. And then again, the follow-up CT image showed the pneumoperitoneum reducing in size. And third, because the patient was in critical condition, requiring intubation and was on multiple sedatives, as well as a norepinephrine infusion, as well as IV fluids, it would make the patient a high surgical risk candidate. And so again, pneumoperitoneum is a rare complication of CPR that may be due to a ruptured abdominal viscus, diaphragmatic leak, or gastric distension. And there are various proposed mechanisms for the visceral injury during CPR, which include transmitted pressure through the diaphragm during chest compressions, incorrect hand placement, increased susceptibility of abdominal organs to injury due to ischemia, forceful delivery of rescue breaths, as well as esophageal intubation. There is a proposed algorithm while approaching cases like such. But yeah, that concludes our presentation.